Madam, have you unshared your screen? If your screen is shared, can you please unshare your screen? If your screen is shared, can you please unshare your screen? Check. Am I audible?
Could be a little more louder.
Am I audible, Dr. Ivan?
Yeah, now you are audible.
Okay, thank you so much. Thank you. So good evening and welcome to this international webinar at Believers Church Medical College and Hospital. This is our 79th webinar, and the specialty for the day is anesthesiology and pain medicine. And the topic for the day is consensus practice guidelines on interventions for cervical spine joint pain from a multi-specialty international working group. To introduce our distinguished speaker for the day and to give an overview of the topic, we have the moderator for the day, Dr. Ivan Koshi. He is the Associate Professor at the Department of Anesthesiology at the prestigious Believers Church Medical College and Hospital here in Kerala, India. So he is an excellent academician and a brilliant clinician. So handing over to Dr. Ivan Koshi. Over to you, Dr. Ivan.
Good evening, everyone. Welcome to yet another webinar session conducted by the Believers Church Medical College. And a very good evening once again to everyone, and good morning to you, Dr. Alison. It's my privilege to be moderating this international webinar on the consensus practice guidelines on interventions for cervical spine joint pain from a multi-specialty international working group. As we all know, neck pain is a very common complaint that we hear very frequently. And neck pain and posterior head pain or cervical spine joint pain is a major cause of disability in people, more so with increasing age. Sometimes it's so debilitating that it restricts the normal activities of the person. There is a wide disparity between patient symptoms and imaging results. Also, there is a variety of management options also, which include intra-articular joint injections, facet blocks, median branch blocks, median branch radiofrequency, ablation, etc. Today here we are here to learn from the experts about the practice guidelines for the management of facet joint pain. Dr. Alison Eng will take us through the latest guidelines in the management of facet joint pain. To introduce her, Dr. Alison is presently working as an anesthesiologist and pain medicine physician at the Northwestern University, Chicago. Prior to this, she worked as an interventional pain physician at the Spine and Nerve Centers of the Virginia's Charleston. She did her Doctor of Medicine from the George Washington University School of Medicine, Washington, D.C., and internal medicine internship from the Georgetown University, Mesta Washington Hospital Center, Washington, D.C. She did her anesthesiology and critical care medicine residency from the Johns Hopkins University, Baltimore, and interventional pain and medicine fellowship from the University of Petersburg Medical Center, Pennsylvania. She has to her credit about over 23 publications and as many presentations. So on this note, on behalf of Believers Medical College, I would like to welcome you, and I hand over the talk to Dr. Alison Eng.
Thank you for the kind introduction. I'm excited to share some of our neck pain guidelines for the future. So my disclosures, I have no relevant financial disclosures to discuss. Today, we're going to talk about the consensus practice guidelines on interventions for cervical spine, facet joint pain from the multidisciplinary, multi-specialty international working group. This, let me just minimize this. So this journal was recently published, this journal article was recently published. Here we have the authors, which there's, so Stephen Paul Cohen is one of the lead investigators, the principal investigator on the study, who is an expert in facet joint pain. This was published in a peer-reviewed journal from the Regional Anesthesia and Pain Medicine recently in the 2021, at the end of 2021. So why is the cervical spine joint interventions, why are they a hot topic right now? So we look at our Medicare claims encounters database. It's demonstrated that we had 112% overall increase in utilization of cervical medial branch RFAs. The increase of expenditures on RFAs also went up by 53%. Now, the RFAs of the cervical spine do reimburse more, and there's an overall utilization that's been increasing in certain interventions that do reimburse more. So there's a question that the lead investigator wanted to investigate. So the utilization of these interventions is higher than actually the prevalence rate. So even though people are using more cervical RFAs, the prevalence of actually having the diagnosis is not as high as you would expect. So there's a discrepancy there. This discrepancy in the growth of medial branch blocks and intra-articular joint injections, which are what happen around, we do the blocks around the neck to help relieve neck pain, and also the radiofrequency ablation, which helps burn the nerves. Those procedures have increased, and yet the medial branch blocks didn't increase as much as the radiofrequency ablation. Questionably, is it because they don't reimburse as much? So reasons for this disconnect could be practice changes. Maybe people just don't do the intra-articular injections as much. Maybe there's a reduction in the number of diagnosis blocks before an RFA, and that's because if you have a radiofrequency ablation and it's successful in the past, you don't necessarily need another medial branch block diagnostic injection before moving to a radiofrequency ablation. So because you can, if you've had success with it in the past, it makes sense that you would have it in the future. So this increased utilization alters the risk to benefit ratio of treatments. There's practice inconsistencies, there's a lack of widely accepted consensus guidelines, which is also a concern for why has this been going up? Do we have something to help guide us? So this results in increased scrutiny by not only insurance payers and government regulatory agencies, but all people in medicine in general. So, let's come back. So this consensus guideline was put together with the modified Delphi method. The modified Delphi method is a process used to arrive at a decision by expert panelists. These had 15 stakeholder academies, societies, and other organizations such as the Department of Defense, the VA, with a vested interest in spinal joint injections. In order to obtain a recommendation and a consensus, 50% of the panel or more had to agree to come to a recommendation, whereas 75% was required for a consensus. They used the search engines of PubMed, Embase, Google Scholar, Scopus, the Cochrane database of systematic reviews. In addition, they referenced all sections of all manuscripts, which so it shows you that this consensus guideline was put together with a very high level of search engine capability. In addition, there were no limitations on the language or the articles. They were inclusive of all experimental studies for physical exams, anatomy, and technical parameters. They also included case reports for considering the risk mitigation and complications, and topically related new journals that were not yet indexed by Science Citation Index or within PubMed. So this was a very comprehensive review of all of the literature in regards to the neck pain with cervical neck injections. So each topic was graded on a scale from A to D according to the US Preventative Task Force grading of evidence. The reason why they chose this grading guidelines is that this grading permits high grade recommendations in the absence of high quality level 1 studies, which is essential in many areas for putting guidelines together where we don't have all the studies that can guide and direct us quite yet. So if you look at table 2 and table 3 in the article, table 2 shows our grading of evidence. On the left-hand column, A, B, C, D, and I. This grading refers to the magnitude of benefit of the intervention. So obviously, A, the committee recommends this strategy because there's high certainty that the net benefit is very substantial. So you should offer this. Also for B, you should offer. C, you should offer for certain patients. And D, you should not offer. A grade of I means it's incomplete. We cannot say if you should or should not offer. If the treatment is offered, the patients should understand that it's not quite certain what the benefits versus harms are. The level of certainty is different. This is the levels regarding the net benefit, high, moderate, and low. And that's based on the evidence of studies currently out there that were collected, assimilated, and analyzed to either make the recommendation or not. So high shows that a high level of certainty shows that the evidence out there is well-designed, well-conducted studies in representative populations with suspected cervicogenic or facetogenic pain and or compelling evidence from non-randomized studies. The low level of evidence is insufficient to offer because either there's limited number of studies or the size of the patients in each of the studies was too small. There's flaws in their study method and design. There's inconsistency in findings across the studies, and there's gaps in the chain of evidence. There's a high likelihood of bias, and findings are not generalizable to individuals. There's also lack of information on important outcome measures, which are essential. So we're going to dive right into what were all the recommendations. There's 20 of them. We'll try to keep on time for this. The consensus practice guidelines ended up, we'll look at each question. Question 1, can history in physical exam be used to identify painful atlantoaxial? AO stands for atlantoaxial, and AA stands for atlantoaxial and atlanto-occipital, excuse me. AO is atlanto-occipital, AA is atlantoaxial joints, high up in the neck, or to select people for prognostic blocks. So determining if these blocks will predict if they're going to have a successful outcome with the radiofrequency ablation. So first we go in to get the patient's history and physical. If it suggests that we should do a diagnostic block, we will do a diagnostic block. If that diagnostic block is positive, we would, in the past, repeat that for a second diagnostic block. And some people call these prognostic blocks. And then if they're both positive, they would move to radiofrequency ablation. In this case, there's no pathognomonic historical signs or physical exams that reliably predict the response to the AA or AO joint blocks in individuals with chronic neck pain. The Atlano-axial pain does have a little bit more reproducibility and consistent symptoms than the AO joint pain, but that still doesn't change the consensus that there's no historical signs or physical exams. They cannot reliably identify if the cause is AA or AO, but they can guide if we should do an injection. So if the physical exam suggests that maybe the neck pain's coming from way high up in the atlantoaxial or occipital joint, then maybe we can inject them and see if they get pain relief. Then we can move to the radiofrequency ablation because it's likely that that was the cause. This is a grade C recommendation with a low level of certainty. This is question number 2. Can the H&P be used to identify a painful facet joint or to select people for prognostic blocks? Similar to question 1, except it's talking about C2, 3, 4, 5, 6, 7, and 8. Instead of the top 2, it's the rest of the cervical spine. So similarly, there's no single pathognomonic history or physical that can reliably predict if the patient will respond to the facet joint blocks. However, in certain patients, if they have a history of whiplash injury from a motor vehicle accident, so banging their head, and they have this paraspinal tenderness in the muscles that overlie that facet, they are likely going to be associated with responding well to the facet joint intervention. So we should offer that to those types of patients. At least there's a higher grade of evidence. Maneuvers associated with radicular signs, so that's like extending the neck and you get numbness, weakness, or tingling in the hands or down the arms. That means it's probably not so much facet joint mediated. It's more likely the nerve impingement. So that's predictive of a negative diagnostic cervical medial branch block. So when you do select which of the levels of the cervical spine should be targeted, tenderness to palpation under fluoroscopy and pain referral patterns is recommended. Now, most people don't have a fluoroscopy machine in their exam room, so most people just feel where you're having the pain and associate it with the pain pattern. So I don't think a lot of people will be able to implement the tenderness to palpation under fluoroscopy until they bring them into the fluoroscopy suite to do the procedure after they get approval. This is a grade C recommendation with a low level of certainty. Question number 3, is there any correlation between the radiological findings and prognostic block and RFA outcomes? So currently the evidence out there is insufficient to assess if that is the case. To diagnose, just on imaging, can you diagnose if this is the cause of facetogenic pain? Or can you tell if that's going to be a reason they will respond well to the cervical medial branch block or the radiofrequency ablation? So that was given a grade I recommendation. The radiological imaging should be strongly considered, though, when you are planning for the procedure. So even though it cannot tell you if they're going to respond or not, you should get imaging to make sure that there's nothing else that you need to send them to the neurosurgeon for, or there's another pathology or something that could get in the way of performing a successful block. That is also a grade C with a low level of certainty. Question 4, Should physical therapy and or conservative treatment be a prerequisite before prognostic facet block? So most of the time, you cannot do a block until the patients fail physical therapy and conservative measures such as Tylenol and NSAIDs. So is this something that we should be doing? Well, a 6-week trial of conservative management prior to the prognostic cervical facet block seems to prevent unnecessary procedures, and it helps decrease healthcare costs. So the expert panel gave this a grade B recommendation with a moderate level of certainty for a requirement of conservative management before the prognostic blocks in patients with at least 3 months of neck pain. So an official diagnosis of chronic neck pain, given the 3 months, they would give it a grade C recommendation if it's at least a 6-week trial of conservative therapy, and an incomplete recommendation, grade I, for concomitant conservative measures and the prognostic block together. So it's higher. So we don't know if we should do conservative and prognostic, but we do know we should probably recommend requiring some conservative management before prognostic blocks. Question 5, is image guidance necessary for cervical facet blocks and RFA? Well, fluoroscopy or ultrasound should definitely be used for cervical medial branch block. That is given a grade A recommendation with a moderate level of certainty. So we know it will have a good benefit, and the evidence out there, they do have substantial evidence to support this. Intra-articular injections, they recommend fluoroscopy with a grade C recommendation, and cervical medial branch radiofrequency ablation, they also recommend fluoroscopy. That is a grade A recommendation for using imaging, so very high level of certainty to minimize adverse events, and then a grade B recommendation for using fluoroscopy above all the other modalities, such as CT guidance, ultrasound guidance. And then note, CT guidance with fluoroscopy is associated with less radiation than just CT alone. However, it is not widely available and adds significant equipment costs and also increases radiation exposure compared to just using the fluoroscopy alone. So question 6, what is the optimal technique for injecting into the aglino-axial and aglino-occipital joints? Pre-procedurally advanced imaging of the cervical spine should be obtained prior to performing the AA and AO joint injections with a grade C low level of certainty. And when performing AA and AO joint injections, a posterior approach confirming intra-articular. IA represents intra-articular spread using real-time fluoroscopy, or digital DSA is digital subtraction angiography, so where you shoot the contrast and you go live with the fluoroscopy to see if it's in the arteries, to make sure before you inject the local anesthetic, you're not injecting into an artery. And they also recommend both AP, anterior, posterior, and lateral views. That's a moderate level of certainty with a grade B recommendation. There's insufficient evidence regarding the use of CT guidance or ultrasound guidance without fluoroscopy when performing the AA and AO injections. So that was given a grade I recommendation. Also, question 6 was broken up. So I separated it here. Should steroids be used? And if so, what type of steroids? And what are the most common complications and how they can be minimized? So use of steroids in AA and AO joint injections may be beneficial in selected patients, but it was given a grade C recommendation with a low level of certainty because the magnitude of benefit was pretty small. If someone does use steroids, they should use a non-particulate steroid, as the particulate ones have been associated with complete paralysis or numbness, weakness, some kind of nerve damage. So we always choose a non-particulate steroid such as dexamethasone, and you don't want to use more than 1 milliliter during the injection. This is given a grade C, low to moderate level of certainty. Question 7, what is the most appropriate approach to cervical medial branch blocks, and what are the risks, benefits of the different approaches? So this is important to make sure you're actually doing the procedure correctly and that we're not getting another target structure and causing a false positive or a false negative. So the experts recommend that we consider fluoroscopy guided lateral. So just taking the shot from the lateral side for the third occipital nerve, which is TON, and for C3 through C7 medial branches. Fluoroscopic guided posterior oblique for the C8 medial branch, because the C8 is very hard to see on the lateral, excuse me. And the unique anatomic considerations in each patient should ultimately be at the discretion of the treating physician. And then a grade I recommendation was given for needle size. So the short 25 gauge needles to reduce the risk of arterial trauma or trespass into the dura or spinal canal when the lateral approach is used. So you can't see how deep you are when you're just going a straight lateral approach. So they recommend using a shorter gauge needle. The ideal volume for the prognostic medial branch block and intra-articular injections. So this prognostic block again tells us, are they going to respond to radiofrequency ablation? Before we do the ablation, we want to inject with the local anesthetic the medial branches. So they recommend not giving any more than 0.3 milliliters of volume for the cervical medial branches for each of them. And slightly higher volumes can be considered if you're not, your contrast beforehand does not show that you captured the most frequent patterns of medial branch innervation. That was given a grade C recommendation with low level of certainty as well. The cervical intra-articular facet joint volumes should not exceed 1 milliliter total. So that includes the contrast that you give plus the local anesthetic. And that's because you can have capsular rupture if you inject more, or you can have an aberrant injection into either the spinal canal or some other structure that's not targeted towards the joint itself. And this is recommended to enhance the specificity of the block. This is a grade C, low level of certainty. Question 9 asks, do intra-articular facet blocks or medial branch blocks confer therapeutic value? They actually recommend against the routine use of intra-articular injections. So these are falling off with favor amongst interventional pain physicians, as the medial branch blocks themselves are preferred. If they do decide to do an IA, intra-articular facet joint injection, non-particulate steroids should be used. And they only recommend, say, you can consider doing the intra-articular facet joint injection if people have, for more of a therapeutic value, if people are at a high risk from adverse events to if they were to have an RFA. So people with ICDs, implantable cardiac defibrillators, they use anticoagulants. So AC is for anticoagulant use, or they're young, healthy athletes. Or there's a very strong likelihood of success. So they've had the intra-articular injections in the past. Well, we should probably proceed with intra-articular injections today because they've done so well before. So why switch it up? Grade C, low to moderate level of certainty based on the evidence. The routine use of steroids with cervical medial branch blocks should be avoided. So grade D, moderate level of certainty. Remember, these blocks are only to be prognostic to see if they will respond to radiofrequency ablation. Question 10, should bilateral cervical medial branch blocks or RFAs be performed during the same visit? And should the number of levels blocked or denervated be limited to a certain number? So bilateral cervical medial branch blocks can be performed at the same visit. They don't recommend that you have to do them separately, but performing bilateral and multi-segment radiofrequency ablation should not. So remember, the ablation burns the nerves at those endings, and if you this recommendation came from having more than 2 levels. Bilateral has been associated with some people not being able to extend their neck afterwards because the burn took away some of the neck extensors. So that adverse effect, if you were to have just do one side follow up after a week, see how they're doing. It minimizes the adverse, or you can pick up if they had an adverse effect earlier, better than doing just both sides and having a safety issue. So they also recommend performing medial branch blocks at greater than 2 levels simultaneously if there is an absence of compelling evidence that you should. So that's a grade C recommendation with a low level of certainty. So 2 levels or less, unless compelling evidence. So question 11, are Facet, Aglino-Axial, and Aglino-Occipital blocks diagnostic, prognostic, or both? So this goes back to are we diagnosing if this is the problem, or are we predicting, are these patients who respond to this block going to have a successful radiofrequency ablation outcome? So C3 through 8 medial branch blocks meet most criteria as a diagnostic intervention for cervical joint mediated pain. And technically sound intra-articular joint injections, which are usually harder to perform or to get to be a success, they meet the criteria as a diagnostic intervention for cervical joint mediated pain, although they are characterized by high technical failure rates. So that's why the guidelines give this a grade C recommendation with a low to moderate level of certainty. Intra-articular injections are less predictive than medial branch blocks for response to medial branch RFA for C2 and 3 through T1 joints. So that's why intra-articular injections have fallen out of favor compared to the medial branch blocks, because you can't tell if they're going as well as the medial branch block, if they're going to move to an RFA procedure. This was a grade C recommendation with a low level of certainty. So question 11 continued. Although accuracy may be improved with CT guidance and arthrogram, these tools are not well supported in peer-reviewed investigations. So it's not recommended, not required. The intra-articular injections of the atlantoaxial and atlanto-occipital joints with local anesthetic can be diagnostic and provide predictive information for intra-articular steroid injection. So if they did respond well in an intra-articular injection, merely local anesthetic, you can predict they're going to respond well with the steroid injections. This is a grade C, low level of certainty. Question 12, what is the effect of sedation on the accuracy of diagnostic or prognostic intra-articular facet joint blocks and medial branch blocks? This is going to be hard probably to put into practice, as a lot of people come get these injections across different areas, and they expect sedation with it in some practices. So it is recommended to perform the branch blocks without sedation, as their evidence is it can increase false positive. So if you're giving some sedation with Versed and fentanyl, how do you know if they just had a response to did better with the Versed and fentanyl, or was it the block itself that gave them good pain relief? So we should not be using sedation in these cases. The only time it should probably be considered with a grade B recommendation and a moderate degree of certainty are patients who have anxiety, PTSD, and particularly very painful blocks. People that may need a larger needle, have aberrant anatomy. In those cases, we can consider when it's a significant form of anxiety and they can't get the block otherwise. Question 13, what should the cutoff be for designating a block as positive? And is there any benefit in using non-pain score outcome measures? So a positive prognostic block is defined as, I had a pain reduction in my pain of more than or at least 50%. Then you can say, yes, they responded very well to this block. It did good for them. So although you might have more pain relief with a medial branch block, and it should lead to greater pain relief after the RFA, on the cervical spine, the literature out there doesn't necessarily support that. So they gave it a grade C recommendation with a low to moderate level of certainty. The second part of the question, non-pain measures should not be used as the sole criteria to determine success or failure of one of these prognostic blocks, but they can be used in conjunction with the pain assessment. So what was the pain score afterwards? And did you have better function? Could you move your neck more? Could you do some of the activities you need to do, such as drive and turn your head? This was given a grade B recommendation with a moderate level of certainty. Question 14 shows how many prognostic blocks should one perform before a radiofrequency ablation? Well, one of the issues here, why they decided to research this question, is they wanted to maximize access to care. So instead of performing 2 blocks, they recommend a single block before cervical medial branch RFA. So using 2 or more blocks, you might have a more likelihood, if you have a positive response to both, of having a positive outcome to the radiofrequency ablation. But we don't have clear evidence that 2 blocks will result in a significant number of false negative procedures and decrease in overall success rate. So because of that, we don't want to take people out of the category of getting a radiofrequency ablation. If they get 2 blocks, one was positive, the second one was negative, they might have a false negative, and then insurance won't approve them, or they won't get approved to go on to a radiofrequency ablation, which could help them in the future. So this was given a grade B recommendation with a low to moderate level of certainty. Question 15, should electrodes be positioned in a certain orientation or location? And if so, what is that orientation? Does the orientation differ with prior surgeries? This is an important question to look at the technique. So near parallel approach should be used, which means our needles should be in parallel while performing our medial branch RFA. So we don't want them crossing over and hitting structures that we don't want to be targeting. This recommendation includes doing those RFA, radiofrequency ablation, for people with anterior neck surgeries and as well as non-operated spines. It does not apply to the adaptation of other electrode technology, though, such as cooled RFs. There's these new technologies on the market. We're just talking about the traditional radiofrequency ablation. This is a grade B recommendation with low to moderate level of certainty. For surgeries involving the articular pillars of the spine, the modified approach with a posterior, so if you take the fluoroscopy and you look posteriorly with the greater angulation or lateral, this advanced imaging might be necessary for people with multiple lesions that need to be created if necessary. This was given a grade C recommendation, low level of certainty, so using your clinical judgment is paramount in this particular instance. And then when we do the radiofrequency ablation, we usually test where the needles are at. We look at them on the fluoroscopy machine, and then we test with the electrodes in the machine, a sensory stimulation, and do they feel it in the correct spot? If they feel it in the correct spot, then that's good. We test motor. We don't want the motor stimulation. We don't want pain or numbness down the arm. We don't want them to have twitching in the arm because that can be targeting the wrong nerve. So should we even do this stimulation before the RFA? They do strongly recommend considering the use of sensory stimulation when single lesions are anticipated, or if you're going to ablate the C2 to 3 facet. This was given a grade C. When multiple lesions are planned, and usually a lot of times they'll do 3 at a time. So C2, 3, 3, 4, and 4, 5 will be done. In those cases, when multiple lesions they plan on doing, the evidence for sensory stimulation is inconclusive. So a grade 1 recommendation, a grade I recommendation, inconclusive. Motor stimulation may be beneficial for safety and effectiveness purposes. That was given a grade B recommendation with low to moderate level of certainty. So most people will continue with the motor stimulation as to have as a safety check and make sure they're effectively targeting the right nerves and nothing inadvertent. Question 17 asks, is there evidence for larger lesions? Well, what if we just burn a larger area? Are you more likely to get the nerve? as some people have aberrant anatomy. So will this improve our outcomes for radiofrequency ablation? And if so, how can we increase that lesion size safely? So the committee says creating larger lesions with reduced lesion variability may increase the likelihood of lesioning the targeted structures. However, these anatomic constraints limit the extent to which larger lesions can be employed in the cervical spine. So if a larger lesion is used, care should be taken to limit damage to any untargeted structures, such as our vasculature and our neurological structures, cervical nerve roots, the vertebral artery, the deep cervical artery. So you need to make sure we know our anatomy beforehand. We have got good fluoroscopy images. We aspirate before injection. We do our neurological checks before radiofrequency ablation. And then although improved outcomes have been demonstrated with larger gauge electrodes for the third occipital nerve, caution has to be emphasized given what we just discussed, some of those inadvertent target structures being affected. Question 17 asks, is there evidence for larger lesions to improve outcome measures for radiofrequency ablation? So it's the same thing. And how can we increase the lesion size? And if there is concern of lesioning non-targeted tissues, such as those arteries, other nerves, or muscle, but you still need to optimize that lesion size, you can consider doing multi-lesioning with a smaller gauge and shorter active tip. So that's our alternative for safety. And then sequential cannula placement for each targeted medial branch should be no more than 1 to 1.5 electrode widths apart. Because then you start veering into the side of potentially having more adverse effects. So multiple lesions are required when targeting our third occipital nerve, secondary to its relatively large and variable course. So oftentimes we'll do 3. That's a grade C recommendation for using larger lesions. And then grade C level with low level of certainty for the ability of larger lesions to increase the duration of pain relief. So we don't necessarily know if it's going to give us the long-term outcomes that we're looking for. So what are the most common complications of these cervical facet interventions, and how can we minimize them? So checking for intravascular placement, as we spoke about, aspirating before injecting and making sure you don't have any blood return. And then visualizing the spread of contrast. So after you aspirate, we shoot contrast and use real-time fluoroscopy, preferably with digital subtraction angiography, DSA, and ensuring that the contrast doesn't go into neurological structures like the spinal canal or an artery. Then we know we're safe to perform and inject the local anesthetic where the medial branch is. Hopefully you see the spread of the contrast along where you would expect the medial branch to be. This is a grade B recommendation with a moderate level of certainty. So reviewing our advanced imaging, whether it's an MRI or a CT scan of the cervical spine for any aberrations in vasculature or around the facet articular pillars and or the SCOUT ultrasound scan prior to performing the procedure can reduce the risk of vascular complications with cervical facet procedures. So people who might have neck anatomy issues, tumors or things that could push the vasculature anatomy around, then definitely you'd want to make sure you review your MRI or CT scan. And that's a grade C recommendation with a low level of certainty. So question 18, what are the most common complications of cervical facet interventions and how can they be minimized? Again, we're continuing. Question 18 is very long with a lot of recommendations, so we'll just hop along. Question 18, positioning the RF cannula tip in the posterior 2/3 of the C2 to 3 facet and avoiding the anterior part of the inferior C2 facet pillar to avoid penetrating an aberrant loop of the vertebral artery. So that vertebral artery you really have to be careful of, especially higher up in the spine, as you can re-review that anatomy as it's more dangerous up there. And that's a grade C recommendation with low level of certainty based on evidence. Ultimately, the decision to perform as to whether or not to continue an anticoagulant for a cervical medial branch block or radiofrequency ablation should be made on a case-by-case basis after carefully reviewing all the relevant clinical factors. That was a grade I recommendation. The ASRA guidelines do hold still. I would usually follow those and see if the risks outweigh the benefits to continue that or not. So the most common complications, physicians should inform patients of some of these adverse effects. They can have increased pain, dysesthesias, numbness, dizziness, and ataxia, so imbalance issues. And this can last a few days to a few weeks following the radiofrequency ablation. Also, non-particulate steroids should be injected if concern for post-radiofrequency ablation lesion neuritis, so where people have the neuritis afterwards. It's more common the higher up in the neck you go with an ablation and in our younger patients. So you can offer, after you perform the radiofrequency ablation, while the needles are still in place, inject the non-particulate steroid, small amount, and then flush, remove the needle, and let that should help a little bit. Grade C recommendation with low level of certainty. And what are the most common complications of cervical facet? Again, evidence is inconsistent based on low-grade trials for a 2-week course of gabapentin to prevent post-RFA neuritis. Some people researched this in the past, and does it help with that, those neuritis after the RFA? We don't know. It's inconclusive. So grade I recommendation. The 3-day course of NSAIDs immediately, plus the steroid injection of non-particulates that we discussed in the previous slide, that is given a grade C recommendation with a low level of certainty. So in certain patients, higher up in the neck, younger patients, we might want to consider that 3-day course of NSAIDs and the injection of the steroids. So fluoroscopy, we want to do a true AP and a lateral view during the RFA cannula placement to ensure we're not inside the neural foramina that could cause major issues. And then failure to obtain your true lateral can result in inadvertent needle placement in the intervertebral foramen or even the spinal canal, which would cause devastating complications. The contralateral oblique view can confirm the RF cannula tip position, and the absence of sensory motor responses and a radicular distribution in response to test stimulation prior to RFA can reduce the likelihood of injury to the spinal cord and spinal nerve roots. So as we mentioned on previous slides, we want to test sensory and test the motor once our cannula tips are in place and before we ablate the nerves to make sure there's no radicular symptoms going down and you're likely not in the spinal cord or the spinal nerve roots. This is a grade B recommendation with low to moderate level of certainty. The committee also recommends a comprehensive discussion with the patients about long-term and short-term complications that can happen with radiofrequency ablation. In addition, they recommend multi-level and or bilateral RFA of cervical facet joints at a single treatment visit, not do that due to possible loss of function of the cervical extensor muscles. So as we spoke about before, like in a bilateral radiofrequency, burning both, it's been reports of patients losing the ability to extend their neck up, and they had to undergo a major neck surgery by a neurosurgeon due to the complications of doing too many of these ablations at one visit. Physical therapy regimens aimed at restoring the function of these muscles prior to and after the radiofrequency ablation may improve the outcomes. Grade C recommendation, low level of certainty. And then healthcare providers, HCP, represents healthcare providers responsible for managing implanted devices such as deep brain stimulators, implanted cardiac defibrillators, spinal cord stimulators. Any of these implanted devices, you should consult those who are the primary team managing in regards to the planned radiofrequency ablation procedure. So not for the medial branch blocks, but for the radiofrequency ablation for sure. If radiofrequency ablation is performed in the absence of evidence to the contrary, these implanted electrical devices, such as neurostimulators, should be programmed to an output of 0 volts and turned off before the procedure to minimize damaging the device. So we do not recommend using bipolar electrodes in the cervical spine, given the risk of trauma, aggressive, less predictable lesions, and no or judicious sedation should be used, as we mentioned previously. And that will allow the physician to communicate effectively with the patient and allow the ability to detect, is there any potential injury? Is the cannulas, the needles causing harm? Is it hurting the nerves in a certain distribution? And you can pick that up at an earlier stage and reposition the needles. A deactivated neurostimulator should be turned back on following the RFA procedure and reprogrammed to pre-procedural settings. These recommendations have a grade C with a low level of certainty. So checking all the radiofrequency ablation equipment prior to the procedure to ensure that it is properly functioning is paramount, and ensuring optimal positioning and orientation of your grounding pads. So making sure the patient has clean, dry skin, clean shaven, devoid of scars or tattoos. And you want to make sure the grounding pad is on and it's adhering to the patient so you don't have burns during the procedure. This is a grade C recommendation with low to moderate level of certainty. So multiplanar fluoroscopic image guided techniques are important. So taking your AP, your lateral, your posterior, your contralateral obliques, making sure each of your angles are appropriate should be used to ensure your RF cannulas are not in contact with a pedicle screw in the case that they had a surgery, or with cervical instrumentation. You want to avoid thermal injury to surrounding tissues that could augment that. And depending on the type of surgery performed, consideration should be given to the probability of accurately targeting your cervical medial branches in the presence of spinal hardware using the posterior approach. So usually when people do have a history of neck surgery with instrumentation, just going directly to that posterior approach can oftentimes be helpful. The grade C recommendation with a low level of certainty. The committee recommends that if an initial radiofrequency ablation is successful, so you have clinically meaningful pain relief for more than or equal to 3 months after your RFA, it should be offered to patients who experience return of the similar neck pain. So I have the same type of neck pain in the same location, and last time we did the RFA and it worked really well. So you can, instead of doing the diagnostic or prognostic medial branch block, you can go directly to the RFA in this repeat case if it's the exact same. That's a grade B, moderate level of certainty. So do repeat diagnostic blocks need to be repeated, and if so, at what interval? So no more than 2 times a year should we repeat the procedure, because the mean duration and benefit of drop-off and success rates are noted with the repeat RFA. This is a grade B, moderate level of certainty. And although there is a paucity of studies examining cervical medial branch RFA success rates after repeating prognostic blocks, the high success rates reported after empirically repeating RFA indicate they are not necessary in most people. This is a grade C, low level of certainty. So our last question, finally, we come to is, should there be different standards in selecting patients for our radiofrequency ablation in clinical trials and in clinical practice? So trials and practice have very different goals. So the standards for clinical practice and trials should reasonably vary. One, patient selection for medial branch blocks and RFA. The clinical practice wants to err on the side of enhancing access to care, where clinical trials need to more scrutinize who's going to go in for inclusion and exclusion criteria to have a more clean study. And then more non-pain secondary outcome measures should be included for clinical trials, and considering also digital subtraction angiography when evaluating the AA and AO injections in clinical trials. The contralateral approach should be required to improve precision in clinical trials, and excluding patients with implanted devices or spinal hardware, evaluating RFA in clinical trials, as that can cause some confounders too. And then excluding patients on anticoagulation for clinical trials is important to reduce our dropout rate. The grade B recommendation, moderate level of certainty, applies for differences in patient selection and non-pain secondary outcome measures. A grade C, low level of certainty for requiring the contralateral oblique view and excluding patients for implanted hardware, anticoagulants, and requiring the digital subtraction angiography, DSA, for clinical trials. So what are the limitations to this, these consensus practice guidelines? So these are guidelines only. They are not standards. You do not have to absolutely do them. They only guide you. They're more flexible. They allow for variation based on physician's clinical judgment, based on patient characteristics. They provide recommendations in areas of uncertainty. The ideal treatment for one patient may be inappropriate for another. And when there is a lack of high quality clinical trials to guide treatment and a consensus regarding practice guidelines, the development of inclusive guidelines becomes even more important to have a clean clinical trial. It is important to recognize that patients, payers, regulatory agencies, and even providers all have different needs and have different goals. So another limitation is that considering the methodological factors with patients and techniques, without patients and techniques. So included studies were not graded, since all grading scales used to rate evidence quality consider only the methodological factors, while failing to consider the more important aspects of patient selection and procedural technique. So how we perform the procedure, what patients are selected, that's harder to look at, and so it wasn't always considered. And this is relevant because not only technical performance, but also the patient selection plays such a pivotal role in the outcome measures, especially for clinical trials. So that's one short area where this guidelines can be short. And then technical quality scales for facet blocks and RFAs are dated. So there's some flaws and not all of them have been validated. That's a big, which is also why guidelines are being created to help guide us in these directions. The last limitation we'll discuss here is these are selected opinions of interventional pain physicians and experts who have a vested interest in cervicogenic headache or facet joint pain. So these guidelines are just a byproduct of those who experience these opinions. And in our case, it's our pain physicians. Let's go to the next. So the conclusions for our consensus practice guidelines are that these clinical trials evaluating cervical facet blocks and radiofrequency ablation are characterized by widely disparate outcomes, and there is enormous variation in selecting patients and performing procedures. So these are multi-society guidelines. Remember, 15 different stakeholder societies, along with the DoD, the VA. They have been developed to serve as a roadmap to help us improve the outcomes for patients, enhance patient safety, and minimize unnecessary testing and procedures that can cause barriers to care. Unlike standards, these often come from an impeachable authority and define standards of care. These are recommendations that are used to help guide clinicians to make sound judgment and personalize their medicine approach for each patient. So practice of evidence-based pain medicine should consider not only the best available research, but also take into account the clinical experience, the expertise, each of our patients' values, what they can handle, their preferences, and what are the practical concerns. I appreciate the invitation to speak, and I hope that we've all learned something from some of these guidelines and we can apply them in the future. I will now turn this over.
Thank you, Dr. Alison. It was a wonderful talk, and it was quite elaborate and extensive and very comprehensive. I probably couldn't comprehend a lot of things, but since we don't practice it over here, at least we could know the consensus which you're following there for the cervical pain, joint pain blocks, as well as from the international multi-specialty working group perspective. So I would take this moment to ask if there's any questions from the audience regarding this topic. The topic is open for discussion. Anyone from the audience?
Dr. Engel, we have a question from one of our residents.
Okay.
Yeah, this is, what are your limitations while you practice cervical injections and these practices in your practice? What are the challenges that you face on a day-to-day basis, so that when we plan in future to probably collaborate and start off this these novel procedures, we can be more abreast of what to expect?
So two things. A lot of people would say insurance payers. So getting things approved by the insurance company, which is why the guidelines here were created. So instead of people getting who are appropriate patients that could really benefit from this procedure, instead of them being denied by insurance, this guideline, you can just hand the insurance company and show them, hey, this patient meets the criteria. This would be beneficial for them in the long run. And second is a lot of patients forget to stop their anticoagulant use. So communicating with patients before they come in, the guidelines, the ASRA guidelines, needing to when to stop and if they need to or not need to. So that risk benefit ratio. So communicating with other providers and the patient.
Thank you, Dr. Alison. And procedure-wise, do you face any challenges?
No, they're fairly easy to perform procedures as long as the patient anatomy is not too, sometimes when you have short, thicker necks, maybe C8 is harder to get to, or higher up in the spine is harder to get to. So using those different approaches, like the posterior approach and having the patient lay face down can really help with that.
Okay. And this question is from one of our house surgeons. Madam, are you performing these procedures regularly, or is it on a research basis that you have been doing it?
So most of the time, our interventional pain physicians, we perform them daily, weekly. Sometimes you'll do 25 to 40 a day, not just neck, but like all different parts of the body. So you might do 20 a week, because people have a lot of neck pain out there.
Okay, that's great. So one of our junior consultants has written, would you guide us to come over to your university to train in these procedures?
Absolutely, we would love that. We will connect and hash out some of the details.
That's fantastic. So, Dr. Ivan?
Yeah, I would have one. I have a question to ask. Dr. Alison, how often do you need to use sedation when you are performing these blocks?
I actually never have had, I think maybe once or twice. Most people can get through this. They're very tiny needles, like baby needles. So I explained to the patients that if you've had an IV placed before, the needles are not any bigger than that, at least for the block. So for blocks, I don't require sedation, but sometimes people who are super anxious, they take a lot of anxiety meds, they don't like needles, they have needle phobia, we might need to bring them back. So I would say maybe once a month or once every 2 months.
So that would be one case every 20 case, 1 out of 20?
Depends. So if you're just considering just neck injections, no, because we probably do at least 20 neck injections a week. So I would say one in 100.
Okay. Yeah. So that is quite less. It's 1 out of 100. So
yeah,
the requirement
sometimes,
is not
right.
that much. So you had mentioned something about the conservative management. What actually would you do for the conservative management initially before going for blocks?
So physical therapy, some people will do rehab, like helping with posture, different neck movements they'll help with. And then your Tylenol, NSAID, some more conservative treatments. Some insurance companies make you trial like tramadol, some kind of opioid, or another trigger point injection, something less invasive. But it oftentimes does not help because I think patients have a hard time finding a good physical therapist.
Thank you. Dr. Jacob, I think.
Yeah, if there are no more questions from the audience, probably we'll take more questions from you and we will send it across to Dr. Alison. She would definitely send us the replies. I think we can close it for now. Dr. Alison, it was an amazing, as Dr. Ivan said, amazing and comprehensive talk and an eye-opener for many of us. Thank you so much. Thank you so much for coming on board, accepting our invitation. And despite your busy schedule, despite your all that you have on hand, you agreed to do this for us. And it was an amazing session. Thank you so much, Dr. Alison.
Thank you very much. It was a pleasure. It was an honor working with you guys. I hope to collaborate in the future and we wish you good luck and enjoy your warm weather.
Oh yeah, oh yeah. That sounds like jealousy.
Yeah, it's great.
We would love to invite you to our country. We are, as you said, as you like it, we are a warm country, and we would love to have you in our institution as a guest speaker, and collaborate with our anesthesia department for various ventures. And on a serious note, we would really love to take it forward. The collaboration part, we just have signed an MOU with the Karlstad University in Sweden, where we have planned for exchange programs among the staff nurses, and also we've gone headway with a few research programs. So similarly, we would love to collaborate with you, your department, and your university as well. And we are excited about it.
Excellent. Thank you. I look forward to collaborating in the future.
Absolutely. Thank you so much, Dr. Alison. You have a wonderful weekend ahead. Thank you so much. And special thanks to the moderator, Dr. Ivan Koshi, and all the participants who are, a few of them who are in this Zoom platform, and also many of them who are in the other platforms eagerly listening to this session. Thank you for tuning in, and we would love to meet you again until the next session, which is on the 28th. We have a cardiologist, international cardiologist, speaking on electrocardiography and certain other important breakthrough initiatives which he's been part of. So we would share the flyer very soon, and until then, goodbye and take care, stay safe. Signing off from Believers Church Medical College and Hospital, Dr. Jacob and Dr. Ivan. Thank you so much.
Thank you.
Thank you.